My name is Doug Smith, and I'm the host of a session here today called Integrating for Better Healthcare Solutions. And I'm joined today by Philippa Lewis, the CEO of Simavita, on my left. And further on my left is Kian, CEO of Independa. And then followed by Davis Brimer, the CEO of Active Life Scientific. These three people you've met yesterday in the context of a Firestarter presentation. Their 5 minutes of fame, cameo appearance, and today we're back for a revisit and a conversation with them in a more interactive kind of way. We're also joined by Frederick Lee on the end. He is one of our panelists who didn't appear in the Firestarter segment yesterday, and he's the Director of Clinical and Translational Informatics at Oracle, and Fred comes from a background deeply immersed in medicine. He's trained as a general surgeon, and now he's working with the Health Sciences Global Business Unit of Oracle. And Fred, I was wondering if you could give us a little bit more of your background and perhaps tie into some of the things that we know about 4P and Lee Hood's visit from last year.
Yeah. So can anyone hear me? Is this mic on? This one? Okay. Thank you, Doug. As Doug had mentioned, I'm going to caveat everything that I say today. So as a surgeon, anything that I say plus $4 will get you a latte anywhere. Before I came to Oracle, I was the founder and the executive director of the P4 Medicine Institute, and I think Lee Hood actually spoke last year at this conference to talk about P4. But really, our vision of the future of healthcare, which we again think we're at a very astounding point in healthcare's trajectory, is that reactive healthcare that really has been in existence and has dominated the industry will transform to healthcare that is predictive, preventive, personalized, and participatory. One of the first steps towards getting to this vision itself is to be able to achieve a high level of data liquidity and digitization in healthcare itself. And at Oracle, we built information management solutions that are allowing that to happen.
Fred, thank you. Thank you. I think having hosted these panels in past years, one of the challenges we're always faced with is where to start, as healthcare is certainly broad and deep, and it's a subject filled with many thorny and seemingly intractable issues. For Pete's sakes, I've been at this for over 30 years, and I don't think I've had any corner on the market of solutions yet. It's also very personal, I think, as Larry Smarr had aptly demonstrated last year and has clearly communicated both in his presentations at FiRe, other places, and of course, the special letter that he put out last fall. One of the things that may help in kind of scoping our discussion is to talk about where we're not going to focus on. And then you can find some of those things by opening up the New York Times or papers here on the West Coast any morning and seeing the kinds of acts and unnatural acts, one might say, that are going on in healthcare in Washington, whether it be the ACA insurance mandate that's being punted around, whether it be compensation issues, whether it be high-tech incentive programs or potentially underfunding of them. What we're looking for is not things that are problems as much as solution spaces, and I think this keeps in the spirit of FiRe and also keeps in the spirit of the challenge that's been put to us, was to look at integration to find better solutions, because I think as we've already explored in the last 36 hours, there's ample opportunities for integration to unlock value, create value. And I think in many industries this is true, but even more so in healthcare, because healthcare in general is, and we may debate about this even on the panel, is very much a non-system. It's a system that has grown up over the course of the last 100 years or so from roots, noble as they might be, which were about individual doctors and practitioners who, while caring for the patients, largely were recognized and rewarded for acting boldly and yet autonomously. And they operated on a finite number of diseases. We really couldn't cure all that many things, and we couldn't do that many procedures successfully. We're very much in an experimental phase. Fast forward to today, and arguably it's a 1 or 2, 10% up or down, but today, medicine recognizes well over 10,000 different diseases and has ways to impact them and potentially even cure many of them. Over 4,000 different types of surgical procedures are routinely performed. Unfortunately, these are led by and reinforced by payment models that are dramatically reinforcing this specialization and the resources that are required to deliver it. We don't cure people with bad knees by giving them aspirins anymore. We replace their knees to the tune of $10,000+. This costs money. It also, again, requires a lot more resource. And one other example, and I'll set the stage for the panel, and that is that in 1970, there was about 2 FTEs of clinical time required per inpatient day. So per patient, about 2 FTEs of clinical time. At the turn of this century, the 21st century, it required about 15 FTEs. So one of the things that we had identified as a panel as an area of potential for integration and perhaps a barrier as well as a solution space is culture. So if you think about this, 2, 15, how do these people operate? How do they interoperate? How do they coordinate their care if their cultural training background and what they're reinforced for is still about independence? It's still about operating as individual contributors, arguably cowboys, trying to do noble things. Also, there's a difficulty in deploying against this cultural barrier, and I turn to Atul Gawande, who many of you perhaps have heard of, as a Harvard surgeon, and also by night he moonlights as a writer and journalist, and I'm not sure which he's better at, but I certainly have appreciated the latter, the reading of his work. He, a number of years ago, took up the challenge with the World Health Organization project to figure out ways to make surgery safer. He looked at adjacent industries that had high safety kinds of issues associated with them, like aviation, and found in there potentially a solution that could be implemented in healthcare, in particular checklists, kind of low-tech, not sexy, not exciting, but as he found out after deploying them in 5 different sites around the world, from India to Boston, they had a dramatic impact on the outcomes of surgery and the safety of it. In fact, they, in and of themselves, reduced the surgical incidence by 35%. They reduced the morbidities that were associated with those surgeries by 47. The checklist was a result of efforts to integrate individuals into a team with a common purpose at a critical moment in the operating room. And it wasn't exciting stuff, but it was an example of where solution space might exist for integration efforts. One of the things that was on the checklist that really struck me was they introduced each other before the blade ever touched a person's skin. And why was that important? Because for the first time in their lives, those 6, 7, 8 people in the operating room may be there for the first time. They may never have met each other. And yet, in the heat of the moment, when things aren't going so well, they needed to operate as a team. So this points to a direction for solutions. And it's not always about money. It's about creatively looking at solution spaces and trying to find ways to address those. And that's why I'm blessed with this panel today. We were able to get together on Wednesday for breakfast and bounce some ideas around. And I think in the course of that, we identified some areas, kind of domains where there might be opportunities for integration and improving things. And each one of the panelists has a different part of this. And I'm going to ask them to engage. So let me just go through what some of these are and then turn it over to the panel to try and figure out which one to engage in, where they think the greatest opportunities are. Obviously, one of them that I touched on was culture, moving away from individual contributors and towards team practice of care. With these 15+ FTEs hovering over me as an inpatient, I sure would like to know that they're talking and coordinating the care that's being delivered to me. Some of the other new ones that we haven't talked about yet are data, integration across touch points. I must have a half dozen different snippets of my medical records scattered around the Portland community in Maine. How do those all come together? That's one of the challenges. Who owns that data? Who pays for it? Who's the responsible steward that brings that data together at the right point at the right time for the care to be delivered? Another area that begs for integration is payment. Historically, we've paid, consistent with this model of delivery, for units of volume, units of care, procedures, not for outcomes. That's changing. Regardless what the Supreme Court decides in June, it's changing. That train has already left the station from what I see in my practice, my management consulting practice. And lastly, and this is something that Davis had surfaced for me, was the opportunity for integration from the bench to the bedside. You know, there's a latency period between when something is discovered and then it becomes common practice. And you may guess that's 2, 3 years, 4 years for this spectacular discovery. I'll tell you the bad news, it's more like 12 to 15 years. So how through integration, and we'll explore what some of those points might be, can we reduce that time? and get that medication, that procedure, that method into practice more rapidly. So let me turn it to Philippa first. Where do you think the areas are to mine? You know, I had a couple headings there, but what resonates with you?
I guess the thing that resonates with me, and coming from my area of interests and expertise, is in ageing, and that is the vulnerability of ageing people. Towards the end of their life, they have complicated conditions, chronic diseases, and certainly acute events that can redirect where they end up, whether that's in long-term care or in an acute care setting. And what's very important is that these ageing people have had maybe 80 or 90 years of their medical history, and they're then deposited somewhere outside of their home, their environment, without any information about their actual medical records, all coordinated in one single piece of data. And that creates a huge risk for that ageing person. And we can see through statistics that improper or inaccurate medical records about your health and your history can cause huge risks and very bad outcomes for you, particularly when you're aged, because when you are elderly, a lot of the events that occur, the illnesses that you have, render you speechless, literally, powerless, possibly without advocacy. And what needs to be with you, if you like, is this chip, some form of information that travels with you, such that anybody who's looking to care for you has a complete idea of the spectrum of your health, your condition, and how you should be managed, so that your outcomes after that event, be it acute or based on a chronic illness condition, you get better outcomes and you can resume your life back at home. So to me, what resonates the most is about the capturing, controlling and delivery of information correctly to people who are vulnerable in the healthcare system. And for me, the interest is in very ageing elderly people who tend to be powerless.
Oh, that's great. That's great. Thank you. Kian, how about yourself?
So that's a perfect setup. Related to the aging population, I'd like to take it outside the medical system because, you know, whoever wants to be a patient in this audience, please raise your hand. So the elderly are no different. And when you're 80 or 90, if you ask someone at 80 years old if they know anyone old, they'll answer, well, yeah, Joe down the hall, he's 105, he's old. So none of us are ever old. We all want to age associate down. And really, the broken system is the episodic treatment of the elderly. And when you go into the system and come back out, there's data that's produced, and absolutely that data would ideally get aggregated. But really, the continuity of the care for that elderly is that much more important. So when you go in for pneumonia 2 years ago and you go in for maybe an ER visit 3 years down the road, what happened in those 5 years? And could we have prevented the ER? And there's a whole economy around that in the US and worldwide called long-term care. Anytime you see billions of dollars being spent in home care, in senior living and independent living, those are the areas that were just touched on that institutions as well as very caring family members are looking to integrate information around that person. And it's important to integrate across activities, across health information, very importantly around social engagement. The number one issue for that elderly person is actually social isolation, which really, at best, is an anomaly for the medical system in terms of how do we treat that. So when you think about integration for the elderly, it has to be a holistic system, integrated across devices, integrated across modalities. And with that, you integrate the family members who actually reduce costs, improve outcomes, and improve lives so that people can be where they want to be longer, safer, more comfortable.
That's great. And I love the way you brought out the idea of patients versus people. You know, everyone is not a patient. Most people don't want to be a patient. And I think Larry brought this out in his talk last year and in the writings. It's, you know, healthcare is not the absence of illness. It's something to aspire to as opposed to the other way around. Thank you. Davis?
Well, this actually is a good segue of moving in the direction that I'm a big fan of when looking at healthcare, which is starting at the end result. What do we want to see happen, and then working our way backwards all the way to the discovery of that in medicine. And so there's this concept called translational science or translational medicine that is becoming much more popular right now. And you referred to the bench to bedside, but it's actually, rather than a line of bench to bedside, it's a loop. bench to bedside, bedside to bench. And so what has become realized over the past couple of decades is that there's a lot of science going on. There's a lot of research. The National Institute of Health manages billions of dollars of funding in the US for healthcare research every year. But Fred and I were just talking about how much data is just sitting in laboratories and nothing's happening with it. There's really no way, or it's very difficult to be able to translate that into something of medical value oftentimes. And so the National Institute of Health, for example, just recently started a new center called the National Center for Advancing Translational Sciences. Congress pumped over $500 million into this center with a focus on how can we better translate these discoveries in the bench, in the laboratory, into the clinical setting. And so we're talking about what we're seeing happening right now. There's definitely a big focus in that. There's a need for better definition of how that's done. But looking into the future, I think that there's also going to be a big push for technologies, and it seems to be a theme that I hear brought up in several panels and discussions throughout this week, of technologies that can translate the data from the benchtop to the patient, measuring the same thing. So this concept of technologies that you can test in a laboratory in a petri dish, but do the same test on a living person. And right now, there's a big dividing gap there. We were talking about atomic medicine, for example. Very difficult to do this kind of medicine on a person. So there's a big push that we're seeing in terms of going from the end result of delivering these discoveries once they're proven and approved to the patients, but also being able to get the discoveries that right now might be 15 years out from the clinic to taking that time down to 10 years, 5 years, a few years, so that we can benefit from that in a much more reasonable period of time.
Good. Thank you, David. And Fred?
Doug, getting back to your the point that you brought up around culture, I am massively ambivalent, if there's such a possible thing, about the incumbent healthcare industry and its stakeholders in becoming, really the driving force in the future of what healthcare and what P4 medicine actually looks like. On one hand, I think there's a lot of optimism or optimistic points that we're seeing. So, in cancer care, I think we're really starting to see what healthcare of the future really looks like. If you have cancer, you're going to get that thing, you're going to get the tumor sequenced. You're probably going to get your own germline sequenced, and if you have any metastases, you're going to get that sequenced as well. And today, oncologists, if you fail first-line cancer therapy, they will start to look at that sequence data in and of itself. And they may see that, well, I know that breast cancer has these 2 primary mutations, but I see that there's these secondary, this other 4 secondary mutations for this patient. Well, I haven't seen this, but let's go look out in the electronic experiential database and see, are there other patients like this? And then let's see if that, maybe they all failed these 3 medications, but for one of them, this 4th medication worked. So you now start to see where digitization in biology and medicine can actually start to impact the clinical workflow by giving that oncologist a clinical insight that they weren't able to have in their own head. Now, you can even extend that a level further because if you start to think about the concept of, I call the query patients like mine, for the physician, and that's complete apologies to Jamie Haywood at Patients Like Me. I know Jamie, I graduated with him at MIT at the same time, and he also owes me $20, so I can be okay with that.
There's a story there.
Yeah, but if you think of, we're starting to talk to some hospital CIOs that say, how do we really drive our web presence in a completely different way? And so we talked to them and said, look, if you had an ability for patients to reach out to other patients that are very similar to them, you then start to be able to create the seed of a little mini social network around that health issue. And today they're finding each other on things like DLife and other websites for that. But this is something very dynamic that you as the hospital have access to all the personal information, electronic health records, transactional systems, research systems for these individuals, but you can bring them together in a very dynamic way. And that is something that healthcare can get into in terms of how do we fulfill the lives of the individuals that are coming to see us. So, there are some points where I'm optimistic where existing healthcare organizations, can survive, thrive, adapt, evolve into the future itself. But frankly, I think that it's going to be a lot of new entrants, areas, white space areas, the elderly, where healthcare isn't really speaking to the needs of the consumers and the individuals, that you're really going to see large vectors of innovation. And just the last thing I want to say is I'm kind of on a little personal crusade to abolish the word patient. And not from an illness point of view, but just follow me on this one. So patient comes from the Latin root patiens, which means one who suffers or one who waits, which probably is no better, description of what.
But equally true today, I guess.
Right. I think, just changing the lexicon around the patient, considering them, first step, considering them as customers would be fantastic. But, ideally, considering them as individuals and members of a social network, a community in some way. If healthcare can start to pivot their focus, that would be fantastic.
Well, that points to another aspect of this culture. I mean, I was going on about the autonomy and some of these deep roots, but there's also central to that team of care that is starting to be put together is the patient, is the person, more to the point. And that's very different from when I was managing medical groups and on the delivery side, where the physician was the center of everything, data, the whole team spun around them. And now that's changing, I think. And I think Larry's insights into the digital and quantifying self is that direction. It's a rise of consumerism. It's all about healthcare more so than disease care, and the desire to get engaged when and where we can. I come back to Philippa's point where, how does this happen? It comes by the ubiquitous of data, the integration of the data, the fact that I steward that data, unless, I'm too old to. And we were talking about this the other day. At some point, perhaps there's somebody else, a loved one, who's tending to that data and making sure it arrives at the right place at the right time.
Commonly that's the case, but I think the goal we have certainly for ageing people is how are we actually going to afford what we're trying to deliver in terms of care for them. So whilst we're excited about a lot of things that medical science is developing for the rest of us, the big bubble that happens at the end of your life is your aging period, and that's where that's what takes the big chunk of the dollars that are available for any of this to happen. And so right now the model for caring for aging people is highly dependent upon children, loved ones, partners who are caring for aging people, trying to keep them at home. And they try to keep them at home because that's what the elderly person wants. But of course, ultimately, when you get so old, you do have to go into some form of care. And the cost differential is a huge gap between the two. So really, I think that the challenge we have is how are we going to actually keep these people at home and keep that data being collected, because elderly people want to stay in control of their health. They're just like us. They want to know how to do it better, how to care for themselves better. And if they've vested their care with a third party, be it family member or whoever, they need to know how to do it better. And the care of an aging person is not dissimilar to our care as younger, healthy people. But there are some complexities that come into your care when you're older that are unique to being old. Of course, one of those things is incontinence, my pet love. Not that I want to have it, but I love to be engaged in this area because it's so complex and so costly. So actually, I think that's a challenge, and that is how does that older person stay in control of their future, in control of their health, keep the costs down for all of us, and only get engaged in long-term care, that expensive part of their life, when absolutely necessary.
It's interesting that we talk about integration for better healthcare solutions, and even on our panel here, I heard some of the sidebar conversations with Kian and Philippa talking about how, hey, I've got something you can integrate into your platform. We just need to be doing more of that. I mean, Philippa could have been just looking at using the technology they've got at her organization in an inpatient or a nursing facility, but they can also be used in the home, and that's where the coordination and collaboration with Kian and his company comes in. I want to leave a couple minutes for Q&A at the end, and perhaps a parting or final comment from each one of the panelists. But are there any questions from the group here? If not, final comments, thoughts?
Yeah, I think, again, we are starting to redefine pretty much every aspect of healthcare. We're starting to look at individuals not as individual patients themselves, but really as the collision between two digital data sets, right? The digital information in your genome and the digital information in your environment. We're starting to capture that data. There's some blocking and tackling in terms of the plumbing. We need to be able to get all that data normalized so it's liquid and you can start to use it. And then, really the next step is who is going to use it? How are they going to turn it back around into value to society, to the individuals, to families, to communities themselves? I think that's a very interesting and intriguing space. Oracle, we've created that first step solution in terms of unlocking that data. And it's really around the innovation communities to say, hey, you've got a new, powerful data substrate for individuals to give them insights, not only into health and illness, but into how you can fulfill their lives in a better fashion. And I'm really looking forward to seeing in the next, 1, 2, 5, 10 years, the trajectory of innovation that's coming on that.
Great, thanks. And David?
It's interesting that obviously we want to empower the people and to give them the choice of the healthcare they get and to give them the information to make the best decisions. But I think it's going to be challenging to do that in certain extents, to a certain extent, meaning that right now healthcare, especially in the U.S., worldwide generally, is a very unique business where the customer is not the payer. The provider does not answer to the payer, meaning that the provider largely has to answer to the customer. So if the customer is asking for the best of care and they're not paying for it, typically there's not much of a feeling of how expensive that actually is. And so there are instances of you can have a new knee made of gold or a new knee made of platinum and diamonds. And the incremental improvement in the results that you're going to get are a half of a percent. Mm-hmm. But of course, if you're not paying for that, you want that. So I think that, back to my original comment on the translational side of things, that helping to bring healthcare costs down by getting things out of the laboratory and into the clinic faster and more efficiently will help to foster this drive of what we're looking for, of empowering the person in their healthcare.
Thank you. We only have less than a minute here, but Kian or Philippa?
Well, we can use 30 seconds.
Okay.
And basically, if you're outside the healthcare system, everyone's a person. In 20 years, we're going to have double 85-year-olds, and half our geriatrician population is today. So the only way we can address it is through technology to help with that. We heard this morning, even including robots, but it is all around integration. The elderly person needs all the data integrated, and they need the care support to be able to reduce costs. Otherwise, we'll have more of a collapse issue in our system.
Good.
I don't think I need that.
Yours is working.
Yeah, I've got 4 seconds, so what can I say? I think there's going to be a very big tussle about who gets the dollars in 30 years' time, because over 30% of the world's population is going to be elderly at that stage, and there'll be nobody here to pay taxes and do the work and so on. So I think that there's a lot of social unrest that's going to flow from this aging demographic, and I agree with Kiana. I think technology has to form part of the solution for that problem.
Good, thank you. I'm going to end with one quote, and this is from Atul Gawande, again, a recent talk that really resonated with me in light of our conversations earlier this week, as well as the theme of the conference. He said it, and I quote, "Making systems work is the greatest task of my generation of physicians and scientists. But I would go further and say that making systems work, whether it be in healthcare, education, climate change, or making a path out of poverty, is the greatest task of our generation as a whole. And that's particularly poignant in healthcare. Thank you. And thanks to my panelists.